Hey everybody, welcome back to another lecture from CyberMD. We're happy to help you learn about the medium vessel vasculitides in this lecture. Please be sure to like, comment, and subscribe to our content so that we can continue to produce free content and resources for medical students around the world. Today we will be discussing Polyarteritis Nodosa, Kawasaki Disease, also known as mucocutaneous lymph node syndrome, and Buerger's disease. Let's start with a quick review of vascular anatomy. The innermost layer is called the intima, which is made up of epithelial cells that rest on a basement membrane. Moving on to the middle layer of the vessel wall, known as the media, it's composed of smooth muscle cells. Finally, we have the outermost layer of the vessel wall, the adventitia, which is made up of connective tissue. Disruption of the intima can lead to thrombosis or the formation of blood clots due to exposure of subendothelial collagen, which can obstruct blood flow and lead to tissue ischemia or oxygen deprivation. Additionally, chronic inflammation of the cells composing the vasculature may result in fibrosis, which may also lead to ischemia as the lumen of the vasculature narrows. All of the pathologies in this lecture will be pathologies that affect the muscular arteries, the ones that supply all of your organs. Now, on to Polyarteritis Nodosa. Polyarteritis Nodosa is a rare disease that affects people of all ages, but it is more commonly diagnosed in the young to middle-aged adult populations. It is also more common in males than females at a ratio of about 2 to 1, respectively. The cause of polyarteritis nodosa is unknown, but it is believed to be an autoimmune disorder in which the immune system is attacking the blood vessels. Certain viruses such as hepatitis B and hepatitis C can trigger the disease as well. Symptoms of polyarteritis nodosa can vary depending on the organs affected by the inflammation, but common symptoms include fever, fatigue, weight loss, abdominal pain, and muscle and joint pain. Symptoms such as skin rash, nerve damage, and kidney problems can also occur, and you may see an elevated ESR or an elevated CRP as well as the other lab findings that are listed on the slide. To diagnose polyarteritis nodosa, complete physical exam and blood tests as well as imaging studies such as a CT scan, MRI, or angiogram may be done. However, a biopsy of the affected tissue is what can confirm the diagnosis. The biopsy would show transmural, so full wall thickness, inflammation of the artery accompanied by fibrinoid necrosis early in the lesion, but fibrosis in the later stages of the lesion. Classically, the way in which the angiography findings are described is a string of pearls. This is due to outpouchings of the blood vessel, which are small aneurysms, that are occurring due to the weakening of the vasculature where the fibrinoid necrosis is occurring. You can see this slightly in the image on the slide if you zoom in, where there are dark circles all next to each other in a line. Keep in mind that this is a buzzword and is unlikely to show up on your exams, so you should think of other ways that they may describe this. Treatment of polyarteritis nodosa involves the use of immunosuppressive drugs to suppress the immune system and reduce inflammation. Corticosteroids, such as prednisone, are commonly used, as well as immunosuppressant drugs, such as cyclophosphamide and methotrexate. Treatment of underlying infections, such as hepatitis B and hepatitis C, may also be necessary. Without treatment, polyarteritis nodosa can lead to serious complications, such as heart attack, stroke, and kidney failure. However, with appropriate treatment, the disease can be controlled and remission can be achieved in many cases. The next disease is Kawasaki disease, also known as mucocutaneous lymph node syndrome, and it is an acute febrile vasculitis that mainly affects infants and young children. It is a disease that is now recognized worldwide as the leading cause of acquired heart disease in children. It's more common in Japan and other Asian countries, but it occurs worldwide and affects all ethnic groups. The incidence is highest in Japan, and children are typically under the age of 5, with a peak incidence between 6 months and 2 years of age. Boys are slightly more commonly affected than girls in this disease. The exact cause of Kawasaki disease is still unknown, but it is thought to be triggered by an infection or an abnormal immune response to an infection or other environmental factor. Several infectious agents have been proposed as triggers, including viruses, bacteria, and superantigens. Genetic factors may also play a role, as there is a higher incidence of Kawasaki disease among siblings and in certain ethnic groups. I say all this to say this is typically a disease that you will see in a child who recently had some kind of illness, typically a viral illness or maybe a bacterial illness as well. The disease is characterized by a fever that lasts for at least 5 days and is typically unresponsive to antibiotics or antipyretics. Other common symptoms include conjunctivitis, mucosal changes such as cracked lips or strawberry tongue, skin rash, lymphadenopathy, and swelling or redness of the hands and feet. In some cases, Kawasaki disease can lead to complications such as coronary artery aneurysms, myocarditis, pericarditis, and arthritis. It's easy to remember the clinical presentation by using the mnemonic displayed on the slides, crash and burn. The diagnosis of this disease is a clinical diagnosis, meaning it's based on clinical criteria. Laboratory tests and blood tests may help to support the diagnosis, but they cannot be the definitive thing pointing you and making you decide that this is Kawasaki disease. Oftentimes, patients who are diagnosed with Kawasaki disease should receive some form of echocardiography so that they can be sure that this child does not have any kind of aneurysms in their coronary vasculature. So the echoes are typically used to monitor for complications in these patients. The standard treatment for Kawasaki disease is intravenous immunoglobulin, or IVIG, and aspirin. IVIG helps to reduce the inflammation and prevent coronary artery damage, while aspirin is used to reduce fever and inflammation and prevent blood clots. Remember that the aspirin is to prevent thrombosis because the vasculitis may damage the endothelium, exposing the subendothelial collagen. Aspirin prevents this by preventing platelet cyclooxygenase activity. And remember that this is the only time where a pediatric patient may present with a viral-like illness and it is okay to prescribe aspirin. Otherwise, you run the risk of inducing Reye's syndrome, which is mitochondrial injury, especially in the liver and the hepatocytes, which leads to a dangerous encephalopathy. Corticosteroids may also be used in some cases, particularly in patients who do not respond to IVIG. Early treatment is critical to prevent complications, and patients with Kawasaki disease should be closely monitored for several weeks to months after their initial treatment. Buerger's disease, the last disease in this lecture, is also known as thromboangiitis obliterans. It's a rare condition that causes inflammation and blockage of small and medium-sized blood vessels, particularly in the arms and legs. It's often associated with smoking and occurs predominantly in men under the age of 50. The exact cause of Buerger's disease is not fully understood, but it is believed to be an autoimmune response triggered by exposure to tobacco products. The inflammation in the blood vessels leads to the formation of blood clots, which can block the flow of blood to the limbs and cause tissue damage and pretty severe pain in some cases. The symptoms of Buerger's disease include pain and tenderness in the affected limb, particularly in the hands and in the feet. This pain can be severe and may occur at rest, but it typically subsides with activity. Other symptoms include coldness and numbness in the limb, changes in skin color and texture, sores or ulcers on the affected area that do not heal. Those are going to be some of the other symptoms. In severe cases, gangrene may occur, which can lead to the need for amputation. Patients with this condition may also experience Raynaud's phenomenon, which, remember, is a vasospasm in the fingers and toes, causing the digits to change color from white to blue and then finally to red as blood flow is restored. The diagnosis of Buerger's disease is based on a combination of clinical symptoms, lab tests, and imaging studies. The doctor may order blood tests to check for signs of inflammation and clotting disorders, and then Doppler ultrasound or angiography may be used to visualize the blood vessels and identify any areas of blockage or narrowing. Finally, the treatment for Buerger's disease focuses on relieving the symptoms, preventing the progression of the disease, and reducing the risk of complications. The most effective treatment for attaining all of these goals is to quit smoking or to quit using tobacco products. If it worsens, it increases the risk for amputation. Medications such as vasodilators and antiplatelet drugs may be prescribed to improve blood flow and prevent clotting. In severe cases, surgical interventions such as bypass surgery or amputation may be necessary. In conclusion, Polyarteritis Nodosa, Kawasaki Disease, and Buerger's disease are all medium vessel vasculitides that you should be familiar with for the USMLE Step 1 exam. While they all fall into this category, demographics, risk factors, and presentation play a large role in differentiating these diseases. Check out the review sheet linked below to compare and contrast these diseases. And again, please be sure to like, comment, and subscribe to our content so that we can continue to provide free medical education resources to students around the world. We hope this video helped, and thanks for tuning in.